I'm Frederick Maynard, and I'm a physical medicine rehabilitation specialist currently from Marquette, Michigan. And I've been involved in seeing post-polio patients and working with Post-Polio Health International now for almost 35 years. And I've seen lots of different post-polio patients in a lot of different settings in a number of the places that I've worked over the years. And I'd like to share some of what I've learned relative to the components for evaluating a post-polio patient. The first thing is to be clear in your own mind as a physician, what are your goals for the evaluation of the post-polio patient? One of them certainly could be the patient, which is fairly typical if you're in a practice situation where a post-polio patient is going to come in to see you because they're having a problem. It's a problem-focused type of an evaluation, and it's important to know how urgent that is. It's something that needs attention, like back pain or a new shoulder pain that's really limiting their function, or is it something that's been going on for a longer period of time? A second goal for the evaluation could be them coming in and saying, I would like a comprehensive evaluation of my post-polio health. I'm having a number of problems, perhaps, or things I'm worried about, and I want to find out whether you can do anything to help me with them. The common ones, of course, are fatigue, new problems walking, feeling that they're becoming weaker, and being concerned about that. A third goal would be a prevention-oriented evaluation. Sometimes that's surprising, where a patient comes in and says, I'm doing all right, but I've been reading about post-polio syndrome and the problems of older polio survivors, and I want to know what I can do to maintain my current state of health and function. And then a fourth goal could be one that's more diagnostic-oriented. The scenario would be a post-polio patient saying, I've been really worried about whether I have PPS, or I've seen someone who thinks I might have PPS, PPS being post-polio syndrome. Okay, well, the essential components of a comprehensive post-polio evaluation would be the same as a physician examining any other patient. It's going to rely on your history, your examination, and then ultimately coming up with diagnoses and a treatment plan or management plan. Okay, now the history for seeing polio survivors is a special challenge and probably one of the most important components of the evaluation. The first thing would be, do they have in fact then a chief complaint or a major concern? Pain is certainly one of the most typical ones that brings a patient in to see a new doctor. But many other times it's fatigue and energy concerns, or it is the concern that they're developing new weakness or changes in the strength that they've been used to. Another one is a change in their ability. I can't walk like I used to. I am having difficulty getting dressed or transferring myself. Another one is, do I have post-polio syndrome? Now, when you take your polio history, the real goal is for you as a physician to get a picture in your mind of what was that polio survivor's function after they recovered from their initial polio infection. Every case of polio is quite different, and therefore you have to spend time trying to clarify exactly how severe was that individual's paralytic polio, and how much recovery and what was their level of function after their recovery was completed. Now the first thing is to review at least briefly, the onset of their polio. How old were they when they had it, and how severe was it said to be, especially during the first weeks and couple of months. Sometimes in our country, in the US, we consider the issue, were they hospitalized? If they were hospitalized, it's more likely that there was a definite diagnosis of paralytic polio that one can be confident of. Getting records is sometimes helpful, but it's relatively unusual that you can find actual hospital records from 30, 40, 50 years ago. Another benchmark sometimes is, did they have a spinal tap? If they did, and then were told they had polio again, that's another increases the likelihood that it's certain that they had paralytic polio. Then the second component of your polio history would be their early functional highlights and the time change of their changes over the initial months. This would be things like, was my right arm involved? Was it my left leg? Was it totally paralyzed? Was it severely weak? How long was it before I was able to try to walk? How long was it before I was able to, in fact, walk by myself? Did I have to use braces? Did I receive physical therapy? Was I treated by my parents that were shown how to do things? What type of devices did I have to use? Was I in a wheelchair for a period of time? The third is what I call the residual functional disability at a person's maximum functional recovery. Now, if you have polio as a child under age 12 to 15, then the period of maximum function will, in fact, probably be when they're in their later teenage years, because you have to superimpose any recovery from the initial paralytic polio with their growth and development. So that's why I use this concept of maximum functional recovery. If they were adults or older teenagers and young adults when they had their paralytic polio, then usually they've reached their maximum neurological recovery in about 2 to 3 years, which isn't to say they may still make further functional gains by further hard work and therapy or with surgical rehabilitation procedures. Then a fourth aspect of your polio history that is very important is to specifically always ask about braces and device use, meaning crutches, canes, wheelchairs, and about reconstructive surgical procedures, including their timing relative to how old the person was and how many years after their recovery. If you have a patient who's sort of vague about in their own memory of what they can do, some of the common questions I found useful is, were you ever able to run? Did you run with a limp? Did you walk with a limp? Could you walk stairs? Did you have to have a railing? Could you walk stairs one step over another, or was it one step at a time? These give you clues as to how severe the weakness was in their legs or their trunk at the time of their maximum functional recovery. Then another fifth component we could call later changes in their function. This is the history now of what's changed in the recent years that will give you some insight as to whether they may have post-polio syndrome or what may be contributing to their chief complaint of pain or weakness or fatigue. Certainly because of the definition of post-polio syndrome that I'll review in a minute, the issue of whether it's actually been 15 years of stability before people notice a new weakening, more difficulty walking, a new limp, a tripping, more difficulty lifting their arm. These are some of the changes that you might run into seeing. And then lastly, you want to know, what is their current functional capacity? Okay, what is it? How far can you walk today? How fatigued do you get? Do you develop pain then? Can you still move yourself in and out of a wheelchair? Can you still feed yourself, dress yourself, take your full bath, or do you need assistance? Okay, then moving on, a third or second really important component of your polio history is your past general medical history that you need to review. Do they have any new chronic conditions that have been diagnosed, or perhaps they've been long-time ones? Have they been a diabetic since they were children? That's possible. Have they developed heart disease? Do they have high cholesterol, high blood pressure? What about breathing problems? Have they had any injuries? Injuries are extremely important because of the difficulty sometimes recovering from an injury if you're a paralytic polio survivor with significant residuals weakness that affects your functional capacities. Another one would be any surgeries. Perhaps now I'm not talking about surgeries, reconstructive or rehabilitative surgeries, but surgeries for something as simple as an appendectomy or a gallbladder removal, or a surgery for a broken bone, a heart attack, for cancer. These are some of the conditions and injuries you certainly want to know fully about. And it's not just that they occurred, but when did they occur? Because the timing of those new conditions relative to the onset that the patient has told you or will tell you about of new weakness, new pain, new functional difficulties is important relative to ultimately being able to decide in your own mind whether they meet definitions for post-polio syndrome. Then a fourth component is certainly a traditional review of systems relative to their health now in the last few weeks or months. And here's where, if you haven't run into already, you're going to want to know, do you, in a more specific questioning, direct questioning, do you feel you're weaker now than you were some years ago or at your maximum functional recovery? How much weaker? Can you give me some examples of how your function has changed? Is it your right arm, your left leg? Do you think it relates to any of these injuries or other conditions that may have happened in the meantime? Other ones are certainly, what is your energy level? How much trouble with fatigue are you having? How are you sleeping? Sleep problems, weight change are very important. The other is always review again swallowing problems, because swallowing and then of course breathing problems, very common among polio survivors, particularly those with a history of bulbar polio involvement early on. And so you want to make sure you really have found out whether that's currently a problem for them and whether it's worsening. Then I would like to emphasize that you need to review their medications. That would be typical. But in today's American society anyway, many older people are on many medications. You need to know why. That's another way of finding out the conditions that they may have been through and whether any of those conditions could be accounting for some of the symptoms that could also occur just directly as a result of post-polio syndrome. Then fourthly, I would mention family and social history, of course. You want to know that they don't have other family diseases. This is particularly important if their history of polio makes you not entirely certain that it really was paralytic polio. But another important part of their social history are their health habits, their lifestyle. Do they exercise regularly? What is their work? How physically demanding is it? What about, are they married? Do they have family? Are things stable? Are they dealing with marital discord? Are they dealing with worry about their children? Have they retired, or they're worrying about their retirement and their enough money to meet their obligations or maintain their lifestyle? These are some of the important issues. They look at the issue of stress in the person's life. Okay, well, let's move on then to examination. I like to encourage people to start their examination with their observations so that during their history taking, they will have been watching the patient relative to their gestures, perhaps, their facial expressions, their emotions, their sitting postures, how they may or may not use their extremities in gesturing. Another important part of observation is their habitus. Are they heavy? Are they tall? Are they small statured? Okay? Do they seem within normal size, but there's obvious deformities or atrophied limbs? Then you make a decision to look at some of their general mobility, and I encourage people to have them stand up and walk while they're dressed before you undress them to examine all of their limbs fully, because they're comfortable then. They have their normal shoes or appliances, braces that they may have brought with them that they typically use. So you get an idea how they're normally functioning before you try to break down what types of weaknesses or joint problems might be behind the abnormalities that you pick up and see. So I usually have anyone who is capable of walking to stand up, and I observe how much help they need from their arms, how easily it is to get into a standing position, how stable they seem, and then how they move, their step pattern, their posture. And we'll come back and look at that again. I'm also obviously taking note of any assistive devices or braces that they're using, and any abnormalities in their gait patterns. Okay, then we're going to need to get into an orthopedic examination, and we're going to do a full neurological examination. And for those, you essentially need to have the person remove their clothing in a way that's comfortable, hopefully have a warm room and a table that allows you and the patient to both remain comfortable during a full neurological and musculoskeletal examination. And I only have time here to really, without a live patient, to really demonstrate to you, to review some of the things that you should be familiar with in a comprehensive evaluation, medical evaluation. In the orthopedic part, the important issues are things like joint range of motion and muscle length. Are their hamstrings tight? Okay, do they have joint deformities? Is there instability in the knee joint, in the shoulder joint, very commonly? Eventually, you are going to look at their spinal alignment. If they can stand, you're going to do that in a standing as well as in the seated position. You're going to look at range of motion through their trunk, through their neck, full flexion, extension, rotation, side bending, through their lumbar spine. Is pain produced? And another is their limb length, the size of their limbs. One that is extremely common, so I call it to your specific attention, is leg length inequality and pelvic symmetry or asymmetry as they're laying supine on your examining table for part of your orthopedic range of motion evaluations. Then some of the highlights of the full neurologic examination is certainly manual muscle testing of their muscle strength. And this can be done and is ideally done in a full comprehensive fashion. But certainly it's going to focus into any part of the body, any of the extremities or the spinal column areas where a person is complaining of difficulty or they've had long-standing known polio sequelae. Obviously, during the manual muscle testing, you need to, at times, just screen them in terms of major functional movements, such as perhaps shoulder flexion, extension, or rotation. Other times, that needs to be broken down through inspection and careful manual muscle testing positions, because you're trying to break down exactly which of multiple shoulder flexor muscles could have been involved and to what degree. Are they about the same, or is there some significant variability? Another one is their muscle bulk, obviously, and their tone. And another I like to specifically mention, a lot of people aren't as familiar with it, is the presence of contraction fasciculations, as well as perhaps resting fasciculations. And the reason I mention contraction fasciculations, which are an undulating type of movement in a muscle that is undergoing a strong isometric hold or continuous contraction at a high force. Normally the muscle is fairly firm and you see the contour of the muscle. But if that contour is undulating and changing, we call that contraction fasciculations. And it's a reflection of the fact that there are giant motor units that are rotating, and they're large enough that you can actually see them change the contour of the muscle, as opposed to remaining a visually fused contracting muscle during that maximum contraction. Another one that's important to look at is their tone. Muscle tone is usually decreased to the degree that there's significant weakness, and if it's increased, you have to be suspicious that something other than polio is going on. You want to look at their reflexes. Again, usually reflexes are decreased or frequently absent in muscles that are significantly weakened from old polio. Very occasionally, one does get some minor increases of tone, or occasionally a pathological reflex at the ankle. Those are reported in the literature. They're relatively uncommon and need to be looked at very carefully on a number of situations if they occur. Sensation is important to test, largely now for two reasons. One, polio does not affect sensory nerves, and sensation is expected to be normal in an aging polio survivor if there is not secondary conditions. But there's a lot of secondary conditions and comorbidities of older polio survivors that cause sensory loss. Things like peripheral nerve entrapments, peripheral neuropathies, radiculopathies from the back or the neck, leaving parts of the extremities numb or with abnormal proprioceptive sensation. Coordination is usually at least briefly looked at during the course of these movements, and you would again expect it to be normal or normal from the standpoint of the weakness patterns that the people are otherwise showing. And then lastly, you want to see that they have a normal mental status and a reasonably normal memory, a cognitive status, that there's not a superimposed dementia, stroke, or some other thing that make you suspect other cerebral diseases. Okay, then I would specifically mention to you that a pain-focused evaluation is frequently important for your older polio survivors. Because pain is so frequently the complaint that brings them in and causing them a lot of distress, and because it can cause weakness and confuse the issue of whether post-polio syndrome is present. So what I like to do is, in a pain-focused exam, is specifically say not only where is the pain, does it occur with active movements? Does it also occur or only occur with passive movements? Is it at the extremes of the movement or through the range of the functional movement? Does the pain occur with local pressure in the area of where the patient's reporting pain? Is that the only thing that produces pain during your examination is pressure and pushing on the part? What about weight bearing? If it's in the lower limbs or the spine, does it occur during weight bearing? If it's during gait or movement, what parts of the gait or with what areas during the range of motion of movement, and how does that correlate with your static or your functional examination, or your static or your examination, your movement examination, as opposed to your functional examination? Then I would break down or differentiate what I call a function-focused examination. This would certainly include walking, but could include transferring if that was an issue for the patient that they were struggling with and if they've been a long-standing wheelchair user, or it could be an upper limb function. Can they reach to pick things up or to feed themselves or do their dressing or bathing? If it comes to the gait, then for walking, you're going to again start with now looking at their posture in their spine while they're where they're more exposed, so you can really see their pelvic heights, okay, the symmetry of their spine, the degree of any scoliosis or deformities. Is their center of gravity from the anterior, posterior, and the sagittal planes anterior or posterior, or clearly more to the right or the left? When you have them walk, you may have them walk with or without their braces, or perhaps often we want to see both. That'll help you understand does that brace or the use of that cane, how much of a difference does it make? Is it the right thing? Do they need more bracing or more devices? After we do this comprehensive evaluation, and in my experience, a fairly complete, comprehensive evaluation of this, of a post-polio patient is frequently needed, not only if they're requesting and their overall circumstance is saying that they came for a comprehensive evaluation, but it's often needed if you're going to get to the purpose of a focused-oriented visit. That is, if you're going to be able to help them with their pain problem or their fatigue problem or answer the issue of the new weakness, you have to do the whole comprehensive one, or you're very likely to make a misdiagnosis or lead to a less than optimal or ineffective treatment plan. So the first thing I would mention relative to diagnosis and planning is you have to be honest with yourself. Do you still need more information? And not infrequently, you do, depending on perhaps how many other physicians or hospitals and people that the patient may have seen earlier. One issue is lab studies, okay? Do you really need to do a blood count, to do a thyroid study, okay? Check their blood sugar to be sure that there are not comorbidities that easily can be explaining the symptoms and the findings of the patient you're seeing. Another is, do you need imaging studies? Do you need x-rays? Do you need MRIs of their spine, of their joint? to understand their pain problem or to better define the severity of the deformities you're seeing. Electrodiagnostic studies is another frequent specialized examination that needs to be done. And there are usually two major reasons, I would say, that electromyography is very useful among older polio patients. One is for the polio patient, the patient you're seeing who says they had polio, but in fact, the history is rather vague. They were young, the parents weren't sure, they were in a poor area that didn't have a lot of sophisticated medical health, and their history is not so typical, it's not so symmetrical, the time frame of recovery is a little off, and their examination perhaps doesn't show the typical scattered kind of weakness in different parts of the body. Electromyography can at least confirm that they clearly have a chronic neurogenic condition compatible with remote loss of anterior horn cells that is likely to be polio. Okay? And if it was occurring to the polio epidemics, then you feel quite sure. But you may find that in fact there's a muscle disease, that they do have neuropathies or radiculopathies or other conditions that can be explained by, and the EMG is also important because it confirms the presence of neuropathy, of entrapment neuropathies, of carpal tunnel syndrome, peroneal nerve injuries. Another frequent specialized exam is pulmonary function studies. And again, these may be a straightforward vital capacity that people can do in their offices, or they need to be more comprehensive, including maximum breathing capacities. Frequently, those studies or people that have significant scoliosis, chest involvement, or breathing complaints, history of bulbar polio, we need to get sleep studies because it's so common that people have sleep apneas and nocturnal hypoventilations at night. And those conditions not only cause you sleep disturbances that can leave you tired, but they can really be insidious and lead to weight gain, diabetes, heart disease, and a variety of other very serious medical conditions. And they are treatable, and people can recover major amounts of strength and energy if they are treated, in spite of their other polio residuals. Another issue is, do you need to involve a whole rehabilitation team? Some of this may depend on your own competence and experience as a physician in the neurological and the orthopedic realms. Many times people do a comprehensive evaluation because it's more time efficient. Other times it is more inefficient, okay, and requires lots of visits, and that's not feasible for the patient. But certainly using using your rehabilitation members like physical therapists, occupational therapists, speech therapists, and psychologists as part of a routine or a selected, directed, when needed, part of a comprehensive evaluation is a good idea and frequently very, very helpful. Other times, even as an experienced rehabilitation physician who can do most of that, I still want someone else to do it, okay? Perhaps with more equipment, with more time to focus on some of the problematic areas. Then two last things would be, do you need other medical consultations? Before you embark on a long treatment plan and a series of recommendations and conclusions about your polio patients, do you need a cardiologist to see them and define their heart condition? Because clearly there's some areas that you're concerned about. What about a pulmonary medicine physician? Do they need to see a neurologist perhaps for a more detailed cognitive evaluation or coordination specialized testing? And then lastly, what about medical reports? Maybe they have seen some of these people, but you're not satisfied with what the patient can tell you themselves. You want to see their records or communicate with the other specialists that have seen them, get their reports. Can you get the old reports from when they were first young and had the polio? Then eventually you're going to have to conclude, perhaps at a second or third visit, about the issue of diagnosis. And I would break down your diagnosis issue into four major components. One is, are you satisfied, certainly, first of all, that the patient did have paralytic polio? Secondly, how many general medical diagnoses beside polio does the patient in fact carry? And how severe are those other conditions? Thirdly, because they're so common, I would mention how many specific musculoskeletal diagnoses, particularly musculoskeletal pain problem diagnoses, does the patient have. They got a little shoulder tendonitis and some carpal tunnel and some mild osteoarthritis of their knees and chronic back pain from degenerative disc disease. You want to at least acknowledge those, and hopefully by now you've been able to define their severity and their functional implications. And then fourthly, you're going to have to come to a conclusion about, does the patient have post-polio syndrome? So I just want to briefly then review what are the diagnostic criteria for post-polio syndrome. And these are based on the March of Dimes Consensus Conference in the late 1990s. They're quite similar to the diagnostic criteria from the European Neurological Group. Number one, again, you need to have a prior episode of previous paralytic polio with residual motor neuron loss that is either confirmed through your typical patient history, neurological exam, and if needed, electrodiagnostic testing. Hopefully we'll have done that. Secondly, a period of neurologic recovery followed by an interval, a stable interval of at least 15 years. Thirdly, either a gradual or at times a relatively abrupt onset of new weakness and or occasionally severe abnormal fatigability, that is, a specific muscle loses its power after just a short period of use or a few contractions. That's what we mean by abnormal muscle fatigability, not generalized getting tired fatigue. And the patient may or may not have pain, generalized fatigability problems, muscle atrophy that's visible and identifiable, or pain problems. But they need to have the new muscle weakness, a change of strength from their period of stability. And then number four, which is the most difficult one of the criteria for post-polio syndrome, particularly important in research studies, is the issue of, can you exclude all other medical conditions, orthopedic conditions, neurological conditions that are counting for this critical new symptom of new weakness in their muscles? And I have to say that some of the time it is difficult to be 100% sure, okay? And then you make appropriate decisions, and perhaps it's ultimately not that important to the treatment plan. But from a research standpoint, you'd like to differentiate people who are weakening in the context of having other changes in their medical condition that are significantly contributing to potentially new weakness of fatigue versus ones where they're not. And then lastly, you need to come up with a treatment plan to help your patient. And treatment planning, I would just give you here as a brief review of some typical examples of treatment plan components. These would include things as specific weight loss plans, and so many of our polio survivors do become heavy as they become older and less active. Do they need to use BiPAP or CPAP, something to help with their nighttime breathing or daytime breathing? What about a new brace? Do they need physical therapy? Many of them can benefit from new physical therapy programs, particularly to design an individualized exercise program for improved flexibility, sometimes or not infrequently for some focus strengthening in certain parts of their body where that's still feasible, and perhaps to improve their overall endurance. Do they need a pain management plan, whether it be through physical therapy, through drugs, injections, perhaps surgery? Counseling, okay? Do they have adjustment problems? Are they becoming depressed? Should antidepressant medication, is it needed? Occupational therapy, frequently occupational or physical therapy for pacing, for energy conservation, and teaching people some of the strategies they haven't perhaps figured out by themselves. Peer group interactions is another way that they can often learn those things. And then lastly, the issue about assisted devices. Do we need to add more canes, change their canes, add crutches, new braces, wheelchair? Do they need a wheelchair mobility cart part-time? When should they use it? How much of the time so it doesn't weaken them? And I'd just like to make some final concluding remarks, okay? As you can tell, post-polio patient assessments are really very complex and they can be very time-consuming, but they are important. And certainly they can be done on multiple visits at times, okay, so that you or the patient aren't worn out, or because you do need to involve more people than you knew at the first visit. I want to emphasize that I don't know any other group in which it's even more important than a patient-professional partnership is essential. Not only to review and understand the history, where the patients come from, but what they're experienced and what they are willing to accept and follow through with on their own life. What are their priorities? You're going to begin your management by focusing on your treatment, and perhaps the other goals are more long-term. So you have to differentiate what's feasible now, what's more urgent now, and what in the long term to maintain their optimal health and functioning should be considered. And then lastly, don't lose sight of their overall big picture of health and wellness and focus only on one specific problem that you may be able to help with, or at least refer them to somebody who can do this more holistically. Thank you very much, and good luck in helping your polio survivors. Thank you.